Yeah. So, see, I think what we can do is we can keep it more interactive, because this is uh, mainly about the revision. This all we have seen. We know what is the significant axial length growth, and what is the refraction status, and what is accommodative lag. That video I will upload about accommodative lag. And this is obviously, between our whole course, we have discussed which are the risk factors, and how do you score risky patients who will progress depending on what is the age of presentation, depending on how much is the hyperopic reserve, depending on whether there is a parental history of myopia or not, depending upon the refractive error of presentation. So, and pre-myopia we have already discussed at length. When to initiate myopia therapy. If there are any questions, we can talk or discuss on this also. How much and when to initiate anti-myopia therapy. And we can always help you out in setting up the myopia control clinic. We can train your staff. You can send them here. They can be with us. They can see what we are doing. Myopia calculators will be there in some time to come. They are already there. I think more and more calculators will be available on board. Like I was talking about OBM12 and other machines like Myopia Master, which already has a Brand-Holden Vision Institute calculator, and even Maya has some of the calculators. So this is again the same thing. In brief, I just went through the slides so that we can open the discussion. We can talk about what exactly we have in mind when we talk about how to set up a myopia control clinic. Yes, Dr. Shweta, if there's any question. Yes.
Sir, to the private, as I'm actually doing private practice here in
Yes.
Pune. So I get patients who have been seen by some, say, a general officer, whoever, and have
Yes.
been randomly started on the atropine 0.01 drops.
Very true.
Yeah, and not about the glasses per se, but then they have been started for, say, 3 weeks. They have been using it, then they suddenly stop. Then again they will use it for some time. So, and then they turn up. And if I see a hyperopic defocus, like a proper, when I do the peripheral retinoscopy on that child, am I justified in stopping the drops and then starting him on the lenses?
See, there are multiple layers to the question. Number one is, if he is already putting atropine, are you justified to stop it? Now,
Yeah.
the first question, which is that whether we should stop it or not. Now, the first and foremost point is we have not documented progression. So, if the drops are ongoing, it will be very difficult for you to comment on that. Now, these patients are typically, they will take more chair time, because the problem is that, they have learned something. You have to make sure that they unlearn it and then take what you want to give it to them. So first you have to tell them that, this is not, there is no evidence of myopia progression. Then you have to tell them what you are doing.
Yes. Okay.
Meaning that you are, documenting psychologic refraction, you are doing axial length, you are doing keratometry, so that you have a fair idea that it is a corneal change or a axial change or what exactly is going on. So what I think is, if patient feels that he wants to stop the drop,
Yeah.
because you have to be very, very sure and very straight in telling the patient that, we are only treating myopia progression. If you want to continue the drop, you can continue it, but we have no clue whether you are going to progress or not. Number one, there are more than 20% almost 20% of patients don't progress. Number two, almost 30 to 40% of the patients don't respond to atropine. So all these things, if they are not sequential, it is extremely difficult for you to comment when they come to you with a problem that, the kid is progressing. Now, you have no clue from where you have started. आपका जर्नी कहाँ से स्टार्ट हुआ है आपको भी नहीं पता है, whether patient
No.
progressing or not. So typically it will take time, but gradually I'm sure you will have to sit with the patient, talk with them.
Like the duration of drop that can maybe cause a rebound in that. So if they've just been putting it
Yes,
for three
yes.
weeks, it probably hasn't worked till now.
Yes,
As
yes,
in,
probably hasn't worked. So typically atropine drops will take at least 2 to 3 months before there is some true effect that comes. If it is a higher
right, right.
concentration atropine, maybe there will be a quicker effect. But zero point zero 0.01 typically would take at least couple of months before there is some action from them.
Okay, and in cases of allergies and those stinging sensations in lesser than 1 month period, then in that they become defaulters. Like they will not
Okay. Okay, so
in
I will
how
tell
to
you
do
what
that.
to,
Yeah.
yeah, I will tell you what to do with them. So, if there is allergy, you will have to stop it. There is no, you cannot continue it because if they are allergic to atropine, it is a sulfa drug. I know it is diluted to 0.01%, so the chances of allergy are pretty low. In our own work in last 10 years, easily we must have prescribed 2,000 to 3,000 children. Easily we have seen only 1 or 2 patients who actually had allergy to atropine. The other point that, whenever you put atropine drops, there is a stinging sensation and a burning sensation. This is very common. The reason is, and the reason
Okay, so then mostly
is not.
the intolerance.
No, no, the stinging and burning is mainly because of the fact that atropine, just like ketorolac, cannot be stabilized without being into an acidic pH. So the pH of the drop, if you have litmus paper in your clinic, if you put the drop on the litmus paper, you will see typically its pH should be between 5.6 to 6.2. Now, whenever there is an acidic pH, there will be some burning sensation at least in the beginning. So whenever you put the drop, there will be a burning sensation for at least
Yes.
15 to
Yeah, okay.
20 seconds.
Yeah.
So if the patient tells you that, what you can tell is that if it is not burning, then probably it is not working for that particular patient because that particular formulation is no longer a acidic formulation and the drop will only be stabilized when it is slightly in the acidic formulation.
Okay. Okay. Yes. Okay. Thank you, sir. I was wondering how to deal with that because
You have to
it's very
just tell them.
haphazard. Yeah.
No, no, you just have to sit with them and tell them that, see, these are three, four things. Before you start the drop, I will tell you. And what happens is that over a period of 6, 8 months, your whole of your clinic knows. So then, before they come to you, your optometrist also tells them that, oh, this is because of this. So just like in cataract, post-op, if patient says something, everybody knows. So it is only in the beginning when you start the myopia control clinic, it is a hiccup in the beginning. Later, everybody in the clinic knows that okay, atropine, you are putting atropine. There will be some itching and burning. Why? Because it is acidic pH.
Okay. And do we maintain like a diary with every patient that they, like visit one, visit two,
No,
like
no.
that? Would it be no, nothing? Yeah.
Normally we don't maintain a diary, but there are some typical patients with whom you
Yes.
have to maintain that.
Okay, sir. Yes.
Normally you don't have to because they themselves are quite concerned that the power is increasing.
Okay.
But
And so the last question is the actual length better to do it on immersion or on optical because it's a kid
see,
involved.
it is a if it is a non-contact that is optical, it is optical biometers will always be better. And I
Okay.
think
Okay.
what is happening gradually, Dr. Shweta, is that everybody is gradually moving towards optical biometers for myopia. I think in coming 3, 4 years,
Yes.
we will see that
Yes.
people start buying biometers with autoref.
Okay.
अभी तो क्या है? This is for the first time a formal course is being run for myopia. But this is not going to be like this for another 4, 5 years. In another 4, 5 years, there will be people where they will be knowing about myopia when they start their practice. So all these things happen, for all the beginners, like pioneers or beginners, it will happen. You all are the people who are starting myopia
Mm.
practice for the future generations. So what will happen is that this forms, whatever we do, will form the basis for our next
So
generations
my
to come
so
and follow.
the voice is breaking, sir. Sometimes I can't actually listen.
Acha.
Uh, uh, but I got most of it.
Okay.
Yes.
No,
Yes.
so what happens is that, gradually what will happen is that, more and more people will go towards a dilated autoref with optical biometry itself
Okay,
and
sir.
the
Yeah.
myopia progression curve at the first instant itself. And
Okay.
when you
Okay.
have another 3, 4 months, just like glaucoma, see, the analogy is glaucoma. Just like glaucoma, in the first instant itself that this patient is a glaucoma suspect. Similarly, you will have a patient who is a myopia progression suspect. So that
Right. Right.
you will keep them more close. You will call them after 3 months, you will call them after 4 months. Because
Yes.
the
Uh-huh.
machine itself will give you a software, a printout that he is a high risk patient.
Yes. Okay. I got that. Similar to the, yeah.
Yeah. And
Mm.
so there is a question in chat. What age do you start vitamin D supplementation? What group of patient and what dose? How much it contributes in treatment? This is by Dr. Reena. Dr. Saab, honestly speaking, I there is no evidence in literature that vitamin D supplementation helps in controlling the progression of myopia. Having said that, vitamin D and these vitamins are responsible for multiple small actions. So, if there is a vitamin D deficiency, we should treat it. That is my take on vitamin D. Not that you can start at any age, because in India vitamin D deficiency is quite common. So it is always better, that you can start with a small lower dose and it can be given at any age. Most of the pediatricians do give vitamin D supplementation. So that is a very routine thing that happens in pediatrics. Having said that, we should not think too much into vitamin D helping in controlling the progression of myopia. So what I do typically is that, like today a patient has come, I have seen the patient has myopia. We have measured axial length, we have taken ultra wide field imaging, we have taken keratometry, we have done everything has been done. Now we are not doing anything. So what we tell the patient is, you do environmental modifications, and if the pediatrician feels that you have vitamin D should be given, we can start vitamin D. So these are the two things that we do as an intervention in the first instance, because till there is no progression, we can't treat progression. So we have to wait. If there is no progression, well and good. So that is how we deal with it right now. Not that we truly believe that vitamin D is making a strong impact on reducing the progression of myopia. We overstress environmental modifications. They have to sit outdoors. They have to reduce their screen time. They have to reduce near work. All those things are emphasized a lot.
So actually, if the parents sometimes they ask about the role of vitamin D supplementation because I think nowadays they are reading it around
On the
that it
internet.
has a role.
So there are
So
conflicting reports. Head-to-head
yeah,
reports are there that vitamin D supplementation doesn't make a difference, and there are reports that vitamin D supplementation makes a difference. There's a wonderful article which says that it is actually the outdoor sitting which is causing both vitamin D deficiency and myopia. So there is no, honestly speaking, there is no hardcore evidence that vitamin D is responsible for impeding the myopia progression.
right. So for kids who are not deficient vitamin D, then there's no point in starting a vitamin D for
No, no, not
controlling the
at all.
progress of
No, no,
myopia.
madam, not at all, not at all. You're
Okay,
very
thank
right.
Sir, I have a few questions, sir.
Please tell, madam.
Sir, regarding these two questions which were asked, the first case, usually we have some US-based patients who usually visit us once a year. They don't come between, cannot come for follow-ups. Whenever they come, we do the whole lot of set of investigations, keratometry. We see that there is a progression with a
Yes.
very bad lifestyle. So are we justified in starting this atropine or glasses, or just wait for the lifestyle modifications to kick in first?
No, 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 no. You can see if there is a progression, you can treat progression.
Okay.
Second thing is, if you feel that progression, if they are something, recently there was an article published on super progressors. Now, basically, if they are progressing very quickly, you can even start combination therapy, because you don't know whether they will come back in 6 months, 3 months or no. So if you feel
Yes,
they are
sir.
progressing very fast, you
Mm.
have to talk with the patient that this is what is going on. If you want, we can start combination therapy. If you want to go step by step, we can start step by step, but we would need some data. The problem with the US patients is that in Western countries optometrists take a central role. and they don't measure axial length.
Yes, 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 sir.
In fact, sometimes they even tell them that axial length is not needed for myopia control progression. I recently got a patient, and there was one case I had posted in the group. Patient actually had a power in plus. Patient had minus 1.5 with a cylinder of plus 2.5. And when you
Okay.
transpose it, patient actually
Transpose.
was a hypermetropic patient, and patient was searching for myosmart glasses. They came to India for getting a myosmart glasses made. So I told them,
Okay.
this myosmart, this is not technically possible to make a myosmart. Secondly, if we make a myosmart, your plus power you will retain your plus power. You don't need a myosmart. So there are a lot of especially in Western countries, patients who come from Singapore and Hong Kong are much more better evaluated compared to the Western countries, because the incidence is not much in Western countries. So they have not still woken up to myopia and everything.
Okay. Sir, and one more question, this atropine, stinging and all. Usually we give an add-on teardrops or a tear substitute. Can we do that, or it should not
No,
be
it
done?
is going to burn. You have to tell them it is going to burn. In last so many
No, can
years,
we add a tear substitute for that? Put this one drop, wait for 5 minutes, then put atropine.
see, you are just dilute. See, what you are doing is what is happening is it has got an acidic pH. That
Yes,
acidic
sir.
pH will be neutralized by excessive lacrimation.
Mm.
You are putting a teardrop to dilute the acidic effect.
Yes, sir.
You can do it, but my point is that you have to tell the patient that this is the property of the drop. In
Yes.
some of the instances, I go reverse and I tell them that if it is not happening, you have got a wrong formulation. It will happen. It has to happen, because if you are so positive about it, then they will not be negative about it. Then they know,
Okay.
acha, this is going to happen. See, if
Okay.
they don't expect it beforehand, no, then they come and complain. If they already know that this is going to have stinging and burning, this is the property of the drop, they don't argue about it. They just tell the kid, and it is not more than 10 to 15 seconds.
Okay. If the itching starts, or if there is a hyperemia, then it is allergy, then we have to stop.
Yes, yes. Normally, it is very rare to have with 0.01%. Normally, you don't have much of allergy. It is a sulfa group, but it is too low a concentration to have allergy. But they
Sir,
have been case reports. Yes.
Sir, axial length, we are doing it every 6 months, sir.
Yes.
Oculizer also 6 months, or the central K values are enough?
Every
Keratometry details.
6 months is enough. 6 months is other.
Oculizer also you are repeating,
Oculizer
sir,
you
or
can do
just
after 1 year or 2 years also, because if K is stable, then we are not looking at, we really don't want to look at their oculizer or topography.
okay. And after starting atropine or glasses, the first visit, the follow-up will be
1
after
month,
1 month, then 3 months,
3 months, then 6 months,
then
and
6
then
months, then every 6 months. Okay, sir.
yes,
Thank you.
yes.
Sir, do you give a choice between what glasses to choose? Like if you are giving Hoya, Myosmart or Zeiss, because
See, I will
sometimes they
tell you.
come very educated and they will ask why this and why not that, like that.
So there are two issues with this. The 2 points. One point is whether you give a choice or not, and whether they ask or not. So you don't give a choice, because you have already, see, whenever you're working in a clinic, you are both a clinician and a person who has to look at the logistics. So whenever you are doing a business in terms of prescribing glasses, you don't give a choice. You deal with the company and you crack a deal with them that, okay, I will write your glasses and you give me in this cost. Second thing is, if patient comes to you and tells you that why not Hoya, you don't have to say anything. You just have to, okay, we will make Hoya for you. See, whether you make Hoya or whether you make Essilor or whether you make Zeiss, it doesn't change anything for you. It is just that you have already talked with the company that you are using their glasses. So there is a certain this thing that they should do for your clinic. Either they should do branding for your clinic, or they should help you out with frames, or they should do something additive so that you will be prescribing that only.
Okay, okay, okay.
So you have
Right.
to
Yes.
first find out whether there's a difference in potency or not. If there is no difference in potency, like Hoya, Halt, or Zeiss, if all three of them are working equally good for you, then you decide yourself which glass you want to give. If patient wants to take a particular glass, you can always say, fine, fair enough. It is like, using Alcon versus using AMO or Johnson & Johnson. You have a certain this thing that you will be putting, suppose you will be putting a single piece or you will be putting IQ lens. Patient comes and tells, no, I want techness. Fair enough, we will put techness. Doesn't
Okay.
change your protocol.
Right. Okay, sir.
Dr. Jitendra,
Yes, ma'am.
I had seen a patient, and because it was the first time I didn't tell him anything. Patient went to an optician, and he said you need this myopic progressive
Mm,
glasses,
I know.
Hoya or something.
Mhm.
So only on the first visit they they guided like this. Then luckily patient came back to me and asked whether I should need. Then I told, am I right? I told that
You are absolutely right,
no,
ma'am.
there
See,
has to be some
progression.
progression, and
Yes,
then
yes.
yes, that is what I
See,
explained.
it
But
is
this
like,
happens, like
yes,
optician
yes.
people also
Madam, it
guide.
happens very
So,
frequently. Ye to your
yeah.
patient came back.
Hmm.
There couple of patients who got the glasses made and came to me after 6 months that even with glasses it is progressing. Now you tell me.
Yeah. So
So
how to
no, no, you have to
how to
sit with the
tackle?
patient. You have to
Yeah.
tell the patient that, see, glasses have been prescribed to you, but there is no axial
Hmm.
length. I don't know what progression
Exactly.
you had. We are,
Hmm.
it is very similar to, madam, dealing with glaucoma patient. Some pressure is there.
Yeah.
Somebody has started timolol. Now you have
Hmm.
absolutely no clue because disc is having
Hmm.
0.3 CD. You have absolutely no clue
Yes.
what was there,
Yeah. And they
what
just
was
start
treated.
treatment. Yeah.
Mother, we have to
Right.
tell the
Right.
patient that, there is, we have no idea whether you had progression
Hmm.
or not. And because
Right.
no idea, so
Hmm.
at this point of time, we are not sure whether at that point of time cycloplegic refraction was done or not. Because typically
Hmm.
opticians would not be much into doing cycloplegic refraction.
Hmm. Hmm.
They
Hmm.
should do it,
Right.
but if they are not doing it, so what happens is when the patient comes back for follow-up, the glass power
Hmm.
changes.
Hmm. Hmm.
But there
Right.
is no baseline as to what happened when they saw it for the first time.
I know. And how to deal with patients with cylinder more than -4? Because I think Hoya and both they make
Goya and
cylinder up
Halt,
to 4 only.
they have now come up till 6, extended this thing. They have now come up till 6 also.
Both of them, Hoya
Both of
and
them.
Esler.
I think both of them. Zeiss, I
But,
think Zeiss also, but I will have to confirm. But I think they have come
but
up.
when I asked last week, they said it is up to 4 only.
If that is the case, there is a glass which is made by Dr. Chandrasekhar Chavan, that is known as
Mm-hmm.
Mykido, which can be
Mm-hmm.
made up to minor. We two patients we have given that. I think
Mm-hmm.
one had almost -14 with a cylinder of 4, so he can
Mm-hmm.
make it. He can make any thing for you.
So can you share his number or
Yeah, yeah.
something?
I had
How to
already shared
contact
him.
him?
No, I had already
Okay. Okay.
shared. I will again share it. Not a problem.
Yeah.
Dr. Reena's screen
Okay. Thank
is
you.
sharing. Dr. Reena, your screen is sharing. Okay. I don't know.
Sir,
Okay. Thank you.
sir, if there is a patient who has, say, -6 diopters of myopia at presentation, and there is no documented progression, but there is history that earlier is like 2 years back, his glass prescription was about 3, then it increased to 4, and that. So,
And now
so,
it is
sir,
6.
then, but there is no documentation, like they don't have previous records or anything. So, at
You can
like
start,
now.
but you have to tell the patient that you can start
Yes,
atropine or glasses, but you have to tell the patient that, see, there is no documentation.
yes,
So, because I am concerned about the kid, I am
yes.
starting doing this, but
Okay.
this is the protocol. And
Okay, sir.
we can always tell them that, I am following the protocol,
Yes.
but because already the number has increased and because you are worried, I am
Yes.
starting the treatment.
Okay, sir.
But we have to tell the patient that, this is what has happened. And
Yes, sir.
the only reason why we are doing it is only for their sake. Not that
Yes.
we cannot wait for another 6 months. We can wait
Yes.
for another 6 months also.
Yes, sir. Yes. Okay.
Sir, recently, sir,
Yes, ma'am.
recently I had a patient who was on atropine, 0.01%, 18 months, 18 years finished. Now
18
they
years
want
old.
to
Yes.
undergo refractive surgery. How long we have to wait for this rebound to happen, sir?
6 months.
6 months to 1 year. It's fine.
At least 6 months, you will know whether progression is occurring, rebound is occurring or not. So you can always taper them slowly, and
Okay.
then the rebound is not that sudden, because bulk of the studies which report rebound always have a very sudden stoppage of the drops.
Okay.
That
What is the protocol you follow, sir, for stopping?
What? I didn't get it. Sorry. Can you ask the question again?
What is the protocol for
Can you ask the
stopping, sir?
question?
How do
Sorry.
you taper?
Okay.
How do
So
you taper?
honestly, there is no guide on that. Typically, what everybody does is that if you are putting the drop once a day, you start telling the patient to put it on alternate days for at least a month, and then you try to tell them that you have to put once a week or twice a week for a month, and then you tell them to just stop it. But there are few people who tell them to put alternate days for 2 months, and then it goes to once a week for another 2 months. So they go very slow. What we do is that if I think what happens is that over a period of time, when you will start doing more and more myopia patients, you would realize that almost all of your patients would gradually go from once a day to twice a day to 0.05. ऐसा होगा in coming years, because what happens with 0.01% is that when you start, they don't respond in first 6 months, and then they respond wonderfully for another year, and after 1.5 years or quarter to 2 years, there is a jump because probably they are gone into puberty or near work has increased or they have come to 10th standard, and it jumps, and parents would tell you that doctor, do something, it has suddenly increased, and you would tell them to put it twice a day. So a lot of patients are now on twice a day, and when we were this Sunday, there was a meeting on 0.05%, and a lot of people felt that 0.05% will not be very useful. Whereas in my practice, there are a lot of patients who are now on 0.05% once a day. And so when the time comes to taper them, what I will do is that I would be trying to tell them to do it myatro 0.01% twice a day, use it for 2 months, then make it once a day, use it for 2 months, and then make it alternate days, use it for 2 months, and then stop it. So, I mean, personally, I feel that that is what will happen with most of us. Maybe we may start 0.05% at the first go itself. I don't know how much everybody will be comfortable, but I think 0.05% has a much more stronger control compared to 0.01%. So if you have a patient who is progressing slightly more than you are comfortable with, you can directly also start with 0.05% once a day. And once you receive the peripheral refraction aid, try to use it and try to tell me whether it is, how much helpful it is. And you can, if there's a problem, you can just let me know on the group whether there's a technical problem or technical error. Just have to tell the patient to fix where the light is. I will post a video of that also, and I have to post a video of accommodative lag also.
Yes, sir. Lag also. Thank you, sir.
So for patients
Dr.
which you start on,
Jitendra,
hello.
हाँ, yes, ma'am.
Yeah.
Dr. Reena, please tell.
Yeah. So for patients which on you start on 0.05%. So is it like you maintain the same follow-up like we're doing for 0.01? And for
Yes,
how long, like once you get there's no progression, for how long do you continue with 0.05?
I typically continued for very long. I continued for almost 3 years. I normally don't tend to remove. I mean, theoretically, when we are talking medically, we would say 2 years. But with LAMP 3, as I was discussing or I was talking into the atropine lecture, we normally would, the first publication which we made was for 3 years. So we typically use it for almost 3 years if the patient's age is not 17 or 18. And then we try to taper 3 years or 3.5 years, and then we try to taper him off atropine 0.05%.
Okay. Okay, sir. So and in case it's like not progressing, like supposing if you use it for a couple like 2 years or so and we don't see any progression, then is it good to taper it or we continue for another 1 year? Like what is your
I
experience?
would still say that age will be an important thing. If the age of the kid is only 12 years, I think it is better to देखिए, Atlas study, that is what Atlas study showed, that once you start atropine and you stop at 13 or 14 years of age, these patients after 6 or 7 years, they show similar amount of progression as the patients who did not put the drops.
Yes.
So it is better. So that was one of the conclusions of Atlas study, that atropine eye drops should be continued for a longer time compared to the amount of time for which it was started initially with atom studies.
Right. So and the study also said like if a higher concentration, the chances of rebound is much more.
Yeah, so once you taper, you will be tapering it much more slowly. So the rebound, the incidence of rebound is more with higher concentration if you stop it abruptly. And bulk of the studies have stopped it abruptly. There is no thought process or there is no discussion of tapering the drops. Because
Right.
that is one of the important reasons why there is no guide on how to taper.
Right. Right.
And all this taper honestly has started from India only. There is no such tapering outside India. This all has started because rebound hai, and we as in India, we do lot of small changes in a way which you may practice or I may practice. So
Right.
this doesn't happen in the Western countries, where they are bound by a certain way of doing things, like an X amount of drop. If it has to be given twice a day, they will prescribe it twice a day. But in India, we do a lot of this thing that, if once a day is not enough, you can put it twice a day. Even if the pharmacopoeia doesn't say that you should use it twice a day. So tapering is not really a concept anywhere. I mean, it is not a concept. But yes, it does help because anecdotally, most of us have incorporated tapering in our practice, and that is why we are so confident that if you taper, the rebound is definitely not as bad as it is when you stop it abruptly.
Thank you, sir. Thank you.
Yes, ma'am.
Dr. Jitendra, so according to Dr. Chandrasekhar, he uses red filter glasses and all. So do you use that in your practice or not? And second question is, any role of exercise in preventing progression or not?
Okay, so red light is a very promising technology. Dr. Chandrasekhar is actually into making a indigenous machine to make sure that it is available in India, because low-level red light therapy currently is not available in India. Red filters,
Yes.
yeah, red filters we started using for
Mhm.
pre-myopes. At least
Okay.
9 patients, 8 or 9 patients, I think we have used. We don't have a
Uh-huh.
follow-up data of what happened to them. Devansh
Okay.
was one of the optometrist who was with us in this. So we don't have a data as to what happened to them because that was only 8 to 10 months back. I'm pretty
Okay.
sure that it will work because if red light is working, red filter should work. Red light machine, I think, would be available in another 8 to 10 years because 8 to 10 months because it is one, it is with I think Sidco for before any medical equipment comes, they have to test for its toxicity or adverse effects or higher or lower levels of in short, to test that whether the machine is functioning properly or not. And
Mm-hmm.
role of exercises, madam, I try to explain it to patients like this because they also try to convince that there are some exercises which are going on. In our city of Baroda, we have 3 people who do that. And the role of exercise is not there because we are clearly telling the patients that you don't do near work, and all the exercises
Okay.
that are available are for near.
Are for near.
So what
Yeah.
I tell them is that if somebody is giving you exercise for distance, do it. But for near, I'm trying to tell you that don't even read for near. So exercise
Right.
का तो सवाल ही नहीं उठता है. There is no reason why we will believe that exercises would reduce the power. In fact, I go one step and I try to tell them that if he does exercise, his power would increase because I am
Okay.
trying to tell that don't do anything for near. So if you do exercise
Right.
near and then you come back to me saying the power has increased, that is
Right.
purely your fault. Otherwise, madam, they will go and do the exercise. So you have to tell them that this is actually hazardous rather than, it is similar to, giving them, there are some fraudulent people who do exercises or who give steroids and all those things. So you have to tell them that, this is what is going on.
Right. 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 And how much should we charge for patient who comes for
So charges,
myopia clinic?
so charges are pretty simple. We have to, we can write down that, we are doing a topography, we are doing a biometry, we are doing ultra wide field fundus imaging. All this comes to around 6,000 rupees, including autoref dilated refraction. So
Yes.
we can write it down that the actual cost is 6,000 and
Okay.
or 7,000. And because you are coming to myopia clinic, we are charging you because it's a package. We are charging you 2,000 rupees or 3,000
Okay.
rupees.
Right. Right. Perfect. Okay. Let's see how it goes.
It's all
Okay.
about, madam, there are two issues in this. One is that, as I keep telling, one is that we have to tell our fellow ophthalmologists that this is there. This is
Right.
not, this is not, I'm not practicing homeopathy or unscientific thing. So this is truth. Second thing is that, we have to tell them that this works. Otherwise,
Right.
it is our word against their word. हम
Mm-hmm.
लोग एक दूसरे के साथ ही compete कर, which is not necessary. There are enough patients for everybody.
Ah,
And
true.
we should try to tell them that, see, myopia I am doing, you also do. What is the harm?
What is that?
There is no harm. You try to do all this. See, if you want to do at a certain cost, do it at that cost. But don't tell the patient that axial length is not needed.
Exactly.
If you want to do free, it is your choice. But don't say that this is not necessary.
Yeah.
Myopia
Not
progression
at
is
least
reality.
pass wrong message. Yes.
हाँ, बस.
Yeah.
And that will happen only when all of us will be on the same wavelength.
Same line. Right. Right. True. True. Right. Okay. Thank you.
Thank you. So what I'm going to do is I'm going to post a Google form which will have certain questions just to see, just to evaluate how we have gone through this. And we will do certain certification. We will be sending the certificates also to your place, to the address. Regarding the equipment, if there are any doubts, we can have a Zoom meeting for that also. If there are any questions regarding setup of myopia clinic, you can post it on the WhatsApp. If there are any questions regarding equipment, or if you want to know the addresses of people who are doing it for Zeiss, Halt, or Hoya, we can send the names of the people who are heading in the country state-wise, and which machines you can take. If you want, we can send you the numbers of which particular person you are, I mean, which particular machine you want. Like if you, there are group of people like in optical biometer, there is Myopia Master, then there is Maya, then there is Hewitts has an optical biometer for myopia, and then the fourth one is by Remedio, OBM 12. So these are 4 machines. If you want to have anything on that, I will send you the number. You can contact. If they are not listening to you, you just let us know, because the fact that we have been practicing myopia, they do they do listen to us only because we are into the field since long. Once you have the contact, they will start listening to you also, because you are also one of the first few people who are practicing this thing. This is just started. In coming years, it will change things. Uh, that is regarding optical biometers. If you need any other technical help, if you want to make a myopia sheet, we can send you our sheets. Anybody, any staff, because sometimes when you have a busy practice, you want to train train an optometrist. If they want to come visit us, see the setup, what we are doing, how myopia progression is documented at our place, they are most welcome. You just inform us on the WhatsApp, we can do that. uh, there's a question from Prajakta: how many hours the child needs to wear it? Just needs to wear it for 15 minutes, not more than that, because low level red light therapy is a very short duration, only for 3 minutes. Not I think it is only for 2 minutes. But this thing, we tell them that you can wear this, and it is not a clip. Basically, what we tell them is that you incorporate the red filter with the glass power and make a separate frame, and you can use that frame for 15 minutes. You can sit outdoor twice a day. That is what we are doing currently. And maybe we can all these guidelines. See, the way I practice is pretty simple. That is how I have practiced pediatric ophthalmology also. I have a completely open mind. Things would change. There is no truth. There is no real right or wrong. Things would keep adding. At this point of time, I may say that we practice this particular thing, and in the later years or later months, we may feel that there is more. And see, when vitamin D came, most of the people realized that vitamin D is the answer to myopia, and a lot of people actually started prescribing. More and more data came, and we realized that vitamin A may be a factor, unclear. So we don't push the patient that vitamin D is necessary. But if there is a deficiency, as Dr. Saab said, that if there is a deficiency, we should try to treat that. So more and more, no, more and more information, more and more literature would come as the time comes. The whole purpose of setting up a lecture series is to make sure that I say something, learn something. You also can find out. You can always ask and post questions. See, it is very important to put forth new ideas, new things in the group, because if your peers are not, they are not aware of what is going on, and if your patient walks into their clinic, they would straightforward tell that this is what has happened with us in 2015, 2016, when our patients on atropine used to visit other doctors, and they would just say that this is some homeopathy. We have absolutely no idea what is going on, and this is some drops which he has made. It may help, it may not help. But if you try to make aware everybody, it becomes much easier. There is no competition. We have got only 8 to 10 hours of work. We have enough number of patients. There are some questions: are there any vendor for red light therapy? There are vendors, but right now I think they have given, as far as what I know, is that one of the machines is with Dr. Pawan Varkicharla in LVP, and I think they are doing some trials with Oro Lab and with Arvind Eye Hospital. So they have given the machines there. The machine typically, when I had talked with one of the vendors, it will typically cost between 2.5 to 3 lakhs. So it is something which we have to keep it in the clinic. Patient will come for 2 minutes red light twice a day, which is not very feasible. I think a model very similar to Potter or something will be there, where the machine will have to travel to all the people in the house, and something will come up, because gradually it will change. It is very difficult to have a single machine. Patient travels to your clinic and for 2 minute therapy. It is very difficult to understand that would happen. And in India, buying a machine of 2.5 lakhs for myopia at home, to keep that machine, because patients, they come back to you and they tell you that my kid has not grown up, you take the machine back. So it is very difficult to expect those things to happen in India. Let us see what happens. And we can discuss about what would be the convenient time to visit in group, or you can personally message. I will message you. We can talk about it. Dr. Shweta, also we will talk about it, when can we can talk the convenient dates when you can visit. Who can make ortho K lenses? So there are two groups. One is straightforward. If you are prescribing halt lenses, they do have Lucid with them, and they do give ortho K lenses. That is a US based company, and that is with Essilor. So Essilor does give halt lenses, and Essilor also gives ortho K lenses. The cost of Essilor lenses are obviously higher. Dr. Chandrasekhar Chavan has his own factory. He makes ortho K lenses, but his lenses are slightly expensive. So Dr. Preeti Mistry, who is a partner with his venture, I will share the number of Preeti also, and they can, yes, I can send you the numbers and details. And I think for ortho K, what you have to do is you have to just learn how to take the plunger and how to put the lens. That much you will have to gradually learn. And I think it is much easy. You can also, visit Preeti's clinic, or Dr. Chandrasekhar Chavan whenever he is in the country. Even I think there are 2-3 more people. I think in Delhi there is Dr. Rajiv Prasad, who gives ortho K lenses, and LVP obviously dispenses ortho K lenses. And I think Dr. Yashwant Savji also gives ortho K lenses. I will share the numbers in the group. That is not a problem. So we will close the meeting with this, and we will post one video of accommodative lag, to how to fit the peripheral refraction aid. Number 3, we will post a Google form, just a small assessment, not really trying to assess the knowledge. It is more of a practical thing, and then we will do certification. So best of luck to everybody, and let us keep the group alive. If there are any questions, we will continue to interact on the group. So thank you so much. Thank
Thank
you
you.
for joining.